Hello, I'm Joseph Choukroun from Nice, France. Many thanks to Dental XP hosted me for this webinar. I will speak today about tissue engineering with platelet concentrate and PRF. What are the evidence base? The platelet concentrate are now routinely used in reconstructive therapy. But we have several questions. What is the best protocol? Are the platelet concentrate constantly active? Are these products active both on soft and hard tissue? And how to obtain best result with platelet concentrate and biomaterials? The growth factors are protein having the capacity to induce cell division and cell differentiation. We have a lot of factors, PDGF, TGF, IGF, VGF, etc. The objective is the healing improvement. VEGF is specially dedicated to angiogenesis. PDGF and TGF are for chemotaxis and cell proliferation. To understand the healing, we'll see hemostasis pathway. After the angio, we have bleeding, blood coagulation, and the fibrin clot will release platelets and will release growth factors from platelets and leukocytes. The aim is the new vessel growth and the cell stimulation to obtain wound healing. What kind of protocol do we have to use? PRP, PRGF, or PRF? If we draw blood from the same patient and we apply the three techniques, we will obtain the same amount of platelets in the tube. And what is the difference? If we compare the three techniques for the PRF, we have no manipulation and the reproducibility of the PRF is complete because the technique is automatic. However, the platelets can secrete their growth factors only after clotting. If we compare the clotting to the three techniques, the PRP and the PRGF, we have not immediate clotting, and with the PRF, we have a natural and physiological clotting. We need the fibrin because the fibrin is the main healing matrix for cells and new vessels growth. But we must take care about the structure of the fibrin as it affects the biological function, and the wound healing outcome depends largely on the fibrin structure. The new vessels born into the fibrin. We can see in this video how two endothelial cells are moving to create a new tissue, a new vessel, sorry. And we have the lumen. It seems that it's the bone of a new vessels. If we compare the fibrin structure in the three technique, in the PRP we have a tetramolecular structure between the monomer of the fibrin. And in the PRF, the structure is trimolecular, is the best structure for the new tissue healing. In the three techniques, we have not the same amount of leukocytes. PRP, we have less. PRGF, we have no white cells. And in PRF, we have more than 65%. First, the leukocyte release growth factors. We know that since 2002 and the article from Vibridge. But the presence of white cells is beneficial because with the white cells, we can recruit progenital cells and we can increase the new vascularization as the white cells they are secreting metalloproteinase, and these metalloproteinase are essential for tubulogenesis, and new vessels grow. In the classification of Dohan and Albrechtson, they insist about the fibrin density and the fibrin polymerization. What is the growth factor release in the three techniques? In the PRP, the release is immediate. In the PRGF, we have not yet article about this matter. And in the PRF, we have a very slow release, more than 7 days. What is the growth factor's essential knowledge today? First, the half-life time of a growth factor is very short, 3 minutes, only 3 minutes. And now we know that we need a very stable gradient of VEGF and other factors to induce significant vascularization. And it's logic, because it's like drop by drop irrigation. We must have a constant and regular infusion of the growth factors into the site to get the best activity of these growth factors. And we published with my friends Dohan and Sammartino the slow release of the growth factors from the PRF membrane. And for the TGF, the PDGF, the VEGF, and the thrombospondin, we found that we have a constant and regular release from the membrane into the site. It seems that if we want to select the best protocol, we have only to respect what happens within the human body without manipulation nor associated product. PRF is the most closer technique to the hemostasis pathway, and I named the PRF only a natural, concentrated human blood without red blood cells. The PRF principles are the blood centrifugation without anticoagulant. If we want to obtain a complete natural fibrin, we need to avoid the anticoagulant. At the end of the spin, we will have the fibrin clot, who contains the growth factors, and the essential of the PRF is the physiological clotting. And we can put these clots into the PRF box to obtain fibrin membranes. It's actually the best way to get the fibrin and the growth factors. We have other questions. Are these platelet concentrates constantly active? Honestly, no, because we need to apply specific protocols. We have changes between practitioners. We have differences between individuals, and we need plasma protein. For the specific protocol, we have to apply a specific process, but for each clinical indication, we have a particular use. First, the preparation of the membrane is very simple. We take the clot in the tube and we peel only the red blood cells. The separation is very easy, and we have the complete fibrin clot into the box. We will use the tray and the cover to apply pressure to obtain a fibrin membrane. After a few minutes, but it doesn't matter, we can wait more, 1 hour or more, to use the membranes. And these membranes are very easy to handle and to apply with now this instrument, the pad. We can also use the other extremity for the sinus, and we fold the membrane twice, and we will apply the membrane into the sinus. If we do not respect the protocol, we will have a very poor clot. If we do not respect the protocol, we will have a very poor clot or a reduced size of the clot. In this case, in the same patient, we have the same drawing and we apply three different protocols. And we will have three different clot size. In clinic, we have to apply also a specific process. For example, in the sinus, we must put two PRF membrane under the Schneiderian membrane folded twice. This is the best protocol. When we do graft procedure, we must recover completely the graft if we want to obtain the better result. In the sinus, how to apply the PRF? We can easily apply the membrane folded twice with the pad, one, and the second membrane. It's the protocol for the sinus. For the socket extraction, we have also a specific protocol. The clots are used into the cylinders in the box, and we introduce the clots into the cylinders. And we will scratch with the metallic piston. And we have now three plugs to apply immediately into the socket extraction. In this case, we will apply three plugs. The first, the second, but you can see it's difficult to press with the metal. We must use a gauze to scratch the clots into the socket extraction. For the first is the same. We must use a gauze to compress. And after we will do sutures to maintain the clots into the socket extraction. In this technique, for example, we applied three plugs. It's in that we applied 27 cc of blood. It's only a concentrated human blood. Do we have to use a specific centrifuge? We must take care because the cheap machine, they heat the blood. You see that for example, in the specificity, the temperature is announced at 45, and we can compare several machines, starting the spin with the tubes, and if we analyze the Salvin machine, we see that we increase the temperature to 49 degrees. With the eBay 20, we have a temperature is going low to 21. With the Medifuge, we are going to 18. And our design process was to maintain a very constant temperature during the spin if we want to respect and if we want to have the best chemical process during the spin. We have changes between practitioners. If the surgical procedure is not correct, the result could be wrong. In this case, the surgeon loses PRF after bone grafting, but despite the PRF, the suture opened after a few days because the incision pattern is not good. And we can understand that between beginners and surgeon with a high experience, we will have differences in the results. We have also difference between individuals. Osseointegration or wound healing should be regarded not as an exclusive reaction, but as the expression of on the endogenous basic regenerative potential of bone tissue. We have local and systemic factors to difference the individuals. We have anatomy, we have cell activity, diet, smoking, etc. And for example, in these two pictures, we have two patients with different fibrinogen level, and we will have a different size of the fibrin clots. And we can understand now that PRF efficiency varies between individuals. Platelets alone are not sufficient. We need plasma protein. Since this article from Cheng and Murray from Harvard School, we know that we need platelets, but also plasma protein to stimulate the collagen gene expression. But it's logic, because in the blood we have not only platelets, we have also the plasma. And I proposed since 2006 to add always to the graft the fluid from the clots. And we published in 2011 the concentration of the fibronectin and vitronectin in this fluid. How is the protocol to use the plasma protein? We need to mix the biomaterials with the fibrin pieces, and we need to hydrate the mix with the exudate. This is a membrane, and we cut it in small pieces. It's very easy to cut it. And we will add first the biomaterial, mixing them together first, and after we will add the fluid from the box. Mixing them, and we see immediately that the product becomes sticky. Other question, are the platelet concentrates active both on soft and hard tissue healing? The answer is yes, but in theory. What is the healing in clinic? We need cells, we need hormones, we need proteins, we need growth factors to obtain the healing. It seems that we will have two different situations. First, situation where we have cells. Example, soft tissue, sinus lifting, socket extraction, and we have other situation where we have not cells. When we do an apposition with bone grafts, in the beginning, we have not cells into the bone graft. We need these cells because the fibroblasts reorganize the fibrin matrix and start collagen synthesis. The fibroblasts promote endothelial proliferation, and the rapid anastomosis of vessels is promoted by fibroblasts. Let's go to analyze the different clinical situation. When we want to use PRF and soft tissue, it's very easy because we have numerous cells immediately available. All the techniques are active, PRP, PRGF, PRF. However, with the PRF, we have a longer activity as we have a slow release. The difference is only the slow release. And we can use PRF for root coverage with PRF alone, and we can see how is the result and the thickness of the keratinized tissue after 1 year without any connective graft. We can use PRF alone, and we will have a very nice keratinized tissue. Recently, Sasha Jankovic published a randomized clinical trial between PRF alone and connective tissue graft, and he found that the results are similar. But we can also use both connective tissue graft and PRF to do a very large reconstruction of the gingiva. And I believe that you already saw the webinar or the video from Achille Pevandi on Dental XP. When we want to use PRF in socket extraction, we have numerous cells into the socket. The fibrin is the best scaffold for socket healing. And we will have less resorption because with the PRF, we will increase the phosphatase alkaline production by 8 times more. Example of extraction treated with only PRF, we are not obliged to suture completely the flaps because the fibrin is a natural product and we can leave it exposed, and we will have a very nice result and very low ridge resorption. In extraction, we fill with the PRF and we can cover with another membrane. We leave the socket and the fibrin exposed, and we can see that after 3 months we have a very nice reconstruction of the socket. And the important is that we have a very natural bone. This bone is a vital bone. In this case, we did several extractions. We filled it with PRF and covered with membranes, and we can see after 3 months how the ridge is maintained with low resorption and the case for my friend Alex Demetz, and we can see how the socket is completely filled with bone. In the sinus, we have the same situation. We have a lot of cells because we have a lot of periosteum cells under the Schneiderian membrane first and on all the bone. And if we use the fibrin is the best scaffold for cells growth, and we can use also PRF for perforations repair. In this case, from my friend Marco Del Corso, we have 2 perforation, and he applied the PRF membrane, and we can see how immediately we get the Schneiderian membrane breathing, because the fibrin sticks immediately on the Schneiderian membrane. We can also use PRF as sole biomaterial in the sinus because it's a very good scaffold, and in the crystal technique we don't need to use any biomaterial. Fibrin alone is sufficient. We can use also fibrin in lateral technique, and we have an article from Alain Simon-Piry and Ziv Mazer, and the histology of this bone is completely natural as 100% of vital bone. However, there is a misunderstanding about the time of histology in the articles available in the literature. Usually when we do a graft, we do histology after 6 months. But if we use PRF, the speed of the bone is more rapid, and we have to do the histology earlier if we want to compare the effect of PRF or other technique. We published already an article where we evaluated the PRF effect on bone graft maturation. And we found that with PRF at 3 months, we obtained the same amount of bone than in the control without PRF at 6 months. If we want to do a position bone graft, this technique and this engineering is very complex. We have to respect several conditions to succeed: low contamination, metabolic condition, and vessels growth. Low contamination, we know that in our surgery we have saliva, we have the breathing of the patient, we have sometimes extraction. It seems that the graft will be contaminated often, very often. And if the contamination is low, the bone and the gingiva will organize the defense. But if the contamination is high, it will turn into infection. And there is no consensus actually to prevent this contamination. When we analyze pictures from CT scan on the sinus, we can see that the graft is often non-homogeneous. Why? Let's go to do a CT scan only after 7 days after the surgery. And we see that we have bubbles of gas. The graft is contaminated by anaerobic bacteria during the surgery. Another case, we can see that we have a lot of bubbles of gas. And if we want to reduce the biomaterial contamination during the sinus, I propose to use metronidazole only to protect the graft, not to do antibiotherapy local. And if we reduce the contamination, we will have faster vascularization and faster bone growth. And we will obtain a very homogeneous grafting. This concept was published in Implant Dentistry, and we got with my friends Alain Simon-Piry and Gilberto Sammartino 2 awards in 2008 and 2009 related to these articles. In this article, we see that we have a very nice graft. However, if we do a CT, we can see that we have non-homogeneous graft, and we will have sure bone resorption after a few months or after a few years. We need to respect metabolic condition. We must take care about hypercholesterolemia. I published my first opinion in 2003 about the effect of cholesterol on bone graft. Every time when a dentist called me about a failure or a critical result, my first question is, could you please check the cholesterol? And every time, we find hypercholesterolemia. In this case, the surgeon called me. I had a very huge surgery and very bad healing. I asked him, please check the cholesterol. He told me, oh, he's very young, 35 years. I don't think that it's important. And we found hypercholesterol. In this mail, a dentist called me about a bone loss. And you imagine what was my first question. Please, could you check the cholesterol? And the answer 1 week after is the patient lipid profile returned with LDL high. What is the interference between lipoprotein and bone growth? These lipoproteins are involved into the transport of vitamin D, vitamin E, and estrogen, and cholesterol is one of the precursors of the steroid and vitamin D. But we know since 3 years that the whole metabolism of the cholesterol is into the osteoblast. It's very interesting to understand that all the metabolism is into the osteoblast. And when we have hypercholesterolemia, we have augmentation of LDL oxidized. And with high LDL oxidized, we will have osteoblast apoptosis, inhibition of phosphatase-alkaline, and inhibition of mineralization. In conclusion, we will have a loss of bone metabolism, and we will have an augmentation of fat part of the bone. We have now several publications and recent about negative influence of bone on bone, but there is not yet article in the dental field. I think that we will publish soon an article about this. First, to understand, for example, in France, we have 40% of adults concerned by hypercholesterolemia. And we started a study in Naples University with my friend Gilberto Sammartino to return on the failures. And we found that in 40% of failure, patients had hypercholesterolemia. My opinion today is, if we have a failure of, or if I want to do a bone graft, I have to check first the cholesterol level. However, when we have patients who are treated by statins, it's the treatment of the hypercholesterol, the conditions are more favorable for bone engineering because the statin improve the bone metabolism. And we know that now when we use statins, we increase the BMP expression during bone regeneration. We need also the vessels growth for the success of bone graft. This vessels growth is obligatory, but it must be rapid, it must be thorough for the long-term implant survival. We need a rapid and thorough vascularization for the long-term survival. In this case, the surgeon did a bone graft with autogenous blocks, but he did not succeed in rapid and thorough vascularization, and the bone graft failed after a few months. If we want to obtain rapid and thorough vascularization, we need extracellular matrix, we need growth factors, we need to respect biomechanical conditions. How to get rapid and thorough vascularization? By extracellular matrix. It's the first step for angiogenesis, as the matrix is produced by osteoblasts and fibroblasts. Between the granules, the cells install the matrix, collagen fibers, and if we have the matrix, the vessels should proliferate. If the matrix is fast, whereas the vascularization will be faster. And we will have also BMP release from the cells, and the site will be hermetic to the epithelial contamination. We need the extracellular matrix produced by cell. It seems that we need cells. We need to attract the cells, and we need to induce cell activity. How? We need collagen environment. In this small video, we can see how the cells are active. The activity of the cell is stretching. And this biomatter contains collagen, and you see that we have a very high level of activity. In this other video from Professor Sato in Japan, he put a piece of collagen and a a piece of bone from rat calvaria. And we can see how the collagen attracts the cells. But in the same time, the collagen induces cell activity. Cell activity is stretching. And when the cell stretch itself, the cells produce matrix. It's the key of the understanding of the matrix production. We need collagen. And we need also to understand that the speed of the vessel's growth depends on the concentration and the collagen density. Where is the collagen? In the autologous bone. Autologous bone is the gold standard because the bone is collagen. We find collagen in allograft. We can see how the collagen fibers are organized. 90% of the allograft is collagen. I want to propose a different classification for the biomarkers. For me, we have to separate in biomarkers with collagen and without collagen. With collagen, they are organic, and without collagen, they are anorganic. Organic are autogenous and allograft, and anorganic are bovine and synthetic. But what is the difference between the two kinds of product? It's only about the speed of vascularization. If we have not collagen, we will have less cells and less matrix and less vessels, but also we will have less efficiency of growth factors. I can tell you that we understand now why the PRF or other techniques of growth factors, they have not the same efficiency regarding the biomaterial that we use. When we want to do a graft with the PRF, if we use collagenic biomaterial, we will have more cells, we will have more matrix and better results. With anorganic material, we will have worse results. Question: granules or blocks? The best condition for vessel growth are the granules. When we want to use the blocks, the results are random because the vascularization is more difficult. And I join my friend Fouad Khoury as he tells now that we must use only particulate piece of bone to get the best vascularization. But do we have to use xenograft? Sure. We have of the biomaterial hardness on the bone density. In this article, Angler did the demonstration that strong material, we will have a strong density of bone. And if we use a soft material, we will have a soft bone. And we understand that we have a lot of advantages to mix xenograft and allograft. Allograft for providing collagen and xenograft for providing a more strong density of the bone. In these pictures, we have a nice quantity of bone, but we can see that the lacunae of the osteocyte are large. It's woven bone. And in the third picture, we have a strong bone, and the lacunae of the osteocyte are very small. Example of using a mix of allograft and xenograft. In this ridge resorption, we use the complete mixing, 50-50, and the result and the stability of the volume is very interesting when we mix completely the two biomaterials. How to get rapid and thorough vascularization? We need growth factors, sure, but we need fibrin. We need all the growth factors. We need leukocytes to recruit progenitor cells. We need a stable gradient by the slow release. We need plasma protein. All of these specifications are respected by the PRF. And we have now a new article published in 2011 comparing the PRF and the BMP in sinus lifting. And the result published is that PRF is more efficient in the sinus than the BMP. How to get rapid and thorough vascularization? By respecting biomechanical conditions. It's probably the most important cause of underperformances and biomaterial resorption. We forget to say that the main origin of the resorption is from the gingiva. First, when we do a flap, we have immediately a bone loss. It's known. We published this study the last year in the CFAC symposium. But if we analyze the histologic study, we can see that after the flap, we have a complete disturb of the fibroblast organization. And this disturb of the fibroblast is with a release of ATP from the fibroblast. And the ATP is one of the most stimulator of the osteoclasis pathway. We have also a complex interplay between biomechanical and biochemical signals. This article was published by Mamoto in Nature Medicine, the most famous journal in medicine. What Mamoto said: first, when we have pressure on the graft, we will have poor vascularization. If we reduce the pressure, the vascularization is better. But if we have no pressure, we have the best result. And we can understand why the tension-free flap closure is so important for the healing, because we will have more rapid vessel growth into the flap, fast healing, and less risk of exposure. This article published the next month by my friends Marius Tagman, Maurice Salama, and Hamle Wang. They insist about the tension-free flap closure. But we must also respect that we must avoid any pressure on the graft at the beginning and during the first weeks of healing. If we apply or if we have tension on the gingiva, we will have bone loss. In this case, we see that we have bone loss around the implants and peri-implantitis, but the origin is only about the tension of the gingiva. We have no vestibule, and we understand that with no vestibule, we will have a very high tension every day, and this is why we have bone loss around the implants. It was this idea that we wanted to apply with my friend Roland Torok from Nuremberg. He presented a webinar 2 months ago on Dental XP, and our objectives were rapid vascularization with low pressure. Using collagenic biomaterial, we understand why, low pressure, PRF to enhance the healing, and metronidazole to reduce the contamination. And in this case of double posterior mandibular resorption, Roland applied the screw tenting with collagenic biomaterial, PRF, and collagen membrane, and we did the reentry only after 2 months. As I told before, if we want to see if we have better result, we have to do the reentry earlier. And I return to the time of histology, it's the same. In this case, Roland applied screw tenting with the same protocol, and we can see that the resorption stops at the level of the screws. In vertical apposition is the same protocol, mixing biomaterials to get more strong bone, PRF and pericardial membrane, and the result is really interesting. When we are in the right way in medicine, every time, science comes and confirms that our clinical impression is the best way. There's 2 articles published since few months by Burkel and Goldberg from Atlanta. And what they said, when we have poor vascularization, we will have biomaterial resorption. But why we have poor vascularization? If we apply early pressure, we will have a poor vasculature and a biomaterial resorption. And if we apply a later pressure, we will have more vessels and a complete stability of the graft volume. And I agree another time with my friend Fouad Khoury. When he did this graft with lamellae of autogenous bone, it's only to reduce the pressure from the gingiva at the beginning, but during few weeks. It's the same when we apply the titanium mesh. The titanium mesh stops the pressure from the gingiva. The sonic weld, it's the same concept. It works, but it works because we have no pressure on the graft. We can also now imagine to organize with small titanium mesh, a volume without pressure, and to fill with biomaterials. About this concept of pressure, when we do extraction, filling with biomaterial, and if we want to get the better result, we must avoid the flap closure. We can use the PRF to cover the biomaterial, and we will have a very nice result because first, we have no tension on the flap, and secondly, because we use fibrin membranes to get fast epithelialization. We have other techniques for vascularization improvement. The laser. Why the laser is active? Because the laser improves the vessel's growth. We can use also bone activation. What is bone activation? We do holes with the burrs on the buccal plate. But the question is how many holes? Few, several, 20, 50? First, we'll see the biology. When we do a microfracture or a hole into the bone, we have immediately an inflammation with production of new vessels and increase of progenitor cells. It seems that if we want to do bone activation, we must do it before the surgery, as the stimulation needs around 9 to 12 days to get vessels and progenitor cells. It seems that we can stimulate flapless the buccal plate after a local anesthesia, and we will obtain a natural bleeding without bone perforation. We can also use another technique for vascularization improvement, the shock waves. What is a shock wave? It's the wave of a very high pressure during a very short time. We have two kind of energy. High energy used to kidney stones, and we must use low energy in dental field. What is the interest of the shock waves? It's only to get new angiogenesis. It's the most powerful technique to stimulate the angiogenesis. But we have also stimulation of cells producing BMP and TGF, and we have an antibacterial effect. This technique is applied externally on the cheek. It's very simple and non-invasive. We can apply this technique for osteonecrosis by biphosphonate. In this case, we failed in surgery, we failed in antibiotics, and our idea is to send a lot of vessels to heal the site. And after 6 months, we can see how the bone is completely regenerated and the site was completely recovered by the new gingiva. We are starting now to use the shockwaves for stimulation of bone graft during the healing period. If I want to resume my speech today, if we want bone growth, we have only one condition: vessels. We need only vessels to succeed. However, we can use collagen to increase the vessels growth. We can use growth factors and PRF with plasma protein, etc. Use metronidazole to reduce the contamination. We can use laser, why not? We can use bone activation. We can use shock waves. We can use statins if we have cholesterol. But we must take care about the pressure. And if by chance we apply pressure on the graft, we will cancel all the benefits of the improvement techniques. PRF and tissue engineering is very simple to understand. PRF is only an improvement technique. Simple and efficient because we have fibrin and slow release. PRF and collagenic biomaterial is the best association, and PRF over collagen membrane will allow a fast epithelialization. If we analyze this case, we understand how we fail into the bone in the bone graft. We understand why we fail in the connective tissue graft, because we have more and more tension on the flap. And we proposed to do an incision with apicalization of the flap, and we used the mucoderm is a substitute of connective tissue graft, but we can also use alloderm, dermis, or any kind of substitute. And we covered the mucoderm with a few layers of PRF because we cannot leave the substitute exposed. The saliva will destroy it. And we can see a very nice indication of the PRF. We covered completely the mucoderm with the PRF, and after we sutured to maintain the fibrin on the mucoderm. And we can see how after 1 week we got a new epithelium, and after 2 weeks how was the gingiva. After 3 months, only because it's a case that we have only 3 months of follow-up, we can see that we created a new vestibule. If I want to make a conclusion, first, my question is the PRF active on hard tissue healing? My answer is in biology, nothing is by chance. If we want to be efficient with growth factors or PRF, we must respect several conditions. And these conditions are the protocols and the biologic environment. I would like to thank all my friends, implantologists and perio, because if I can speak about dentistry, it's not my work, as I'm not dentist. Je vous remercie de votre attention.